Welcome, Richard. Come on in. Thank you for being here today. Dr. Anderson is part of our interdisciplinary spasticity clinic. He is our pediatric neurosurgeon, and I would like him to introduce himself.
Thank you, Angela. So my name is Richard Anderson. I'm a pediatric neurosurgeon, part of the Neurosurgeons of New Jersey, and a clinical associate professor of neurosurgery at NYU.
We have some questions from the community we'd like you to answer. What are some options for neurosurgical intervention for patients with cerebral palsy and spasticity?
Thanks, Angela. So there are two main options for neurosurgical intervention. The first one is something called an intrathecal baclofen pump, and the second one is selective dorsal rhizotomy. So an intrathecal baclofen pump is it's a pump that you put a reservoir underneath the skin. On the front here, it's about the size of a small hockey puck, and it's connected to a tube which runs around and delivers baclofen, which some children take orally. It delivers it directly into the spinal fluid. The big advantage is that you can achieve concentrations of the medicine about 100 times more powerful than if you were to deliver it orally, because you're delivering it behind the blood-brain barrier. The advantage of an intrathecal baclofen pump is that you can adjust the dosage of the medicine so that you can go higher or lower to try to fit the individual needs of every specific child. The other option is something called a selective dorsal rhizotomy. This is an operation that's been done in some way, shape, or form for over 100 years. It's just much more elegantly and sophisticatedly performed over the last 30 years with selectivity. And what I mean by that is that during the operation, we have a whole operating team with a neurophysiology team. We have our physical and occupational therapy team under the drapes, manually palpating the muscle groups while we're stimulating nerve roots, and we selectively cut the nerve roots that are causing the most spasticity, so we can tailor it for each child. And of all the types of treatments and intervention for children with spasticity, nothing's been studied more and has longer term outcome than a rhizotomy. We have studies that demonstrate 30-year outcomes after rhizotomy, and it's the most powerful, long-lasting way to permanently reduce spasticity.
We do have multiple patients in the clinic that have underwent a selective dorsal rhizotomy and done very well, and we follow them up regularly in the clinic to see how they continue to progress over the years after the surgery is done. Next question is, what is the plan for rehabilitation after a procedure like a selective dorsal rhizotomy?
It's a great question. So the only wrong thing to do is to choose to move forward with the rhizotomy and not do the rehabilitation afterwards. Because then you're putting a child through the risk of doing surgery, but you're not maximizing the benefit. So all these children, after they recover from their surgery, with a few days in the hospital, they're transferred to inpatient rehabilitation, where they stay anywhere from generally 2 to 4 weeks, where they have intensive therapy up to 2 or 3 hours a day to rebuild the muscle strength and really train these children how to move in a more functional way.
Thank you so much for coming today. If patients want to reach out and find more information about your procedures and being able to see you, how would they go about doing that?
For more information, I just ask families to reach out to my office. Thanks so much.
Thank you.